Welcome everyone to today's session on acute pulmonary embolism, focusing on a comprehensive diagnostic and management approach specifically for non-pregnant adults. This lecture is part of our ongoing medical education series designed to equip you with up-to-date knowledge and practical insights. Before we begin, I want to emphasize that the content we'll discuss is intended strictly for educational purposes. Clinical decisions should always be guided by current evidence-based guidelines, your institution's protocols, and consultation with your supervising physicians. Throughout this presentation, we will explore the critical aspects of recognizing, diagnosing, and managing acute pulmonary embolism, a condition that demands swift and accurate clinical action. Let's use this opportunity to deepen our understanding and improve patient outcomes through informed clinical practice. Pulmonary embolism, or PE, is truly a high-stakes diagnostic challenge for us as clinicians. Its presentation is incredibly variable. Some patients may have no symptoms at all, while others can suffer sudden death. This wide spectrum makes recognizing PE particularly difficult. Missing the diagnosis can be fatal, yet overdiagnosing leads to unnecessary anticoagulation, which carries its own serious risks, especially bleeding. So, we must strike a careful balance in our clinical judgment. Epidemiologically, PE affects about 60 to 70 individuals per 100,000 each year. If untreated, the 30-day mortality rate is alarmingly high, ranging from 10 to 30%, underscoring the urgency of timely intervention. Even after initial treatment, the risk of recurrence is significant, about 5 to 10% within the first year. This highlights the need for ongoing vigilance in managing these patients. In summary, pulmonary embolism demands a high index of suspicion and careful diagnostic strategy, given its potential lethality and the risks associated with treatment. As we proceed, keep in mind the critical importance of balancing timely diagnosis with thoughtful management. Let's delve into what we call the spiral of death in severe pulmonary embolism, a cascade of physiological events that rapidly worsen the patient's condition if not promptly recognized and treated. It all begins with the obstruction of the pulmonary artery by an embolus. This blockage suddenly increases the resistance against which the right ventricle has to pump, known as increased right ventricular afterload. The right ventricle, which is not designed to handle high pressure, begins to dilate and lose its ability to contract effectively. As the right ventricle dilates and its function declines, it impairs the filling of the left ventricle. This is decreased left ventricular preload. With less blood returning to the left heart, systemic blood pressure drops, leading to systemic hypotension. This hypotension, combined with increased wall stress, compromises the blood supply to the right ventricle itself, causing right ventricular ischemia. The ischemic ventricle becomes even less effective, spiraling the patient into cardiogenic shock. Understanding this sequence is crucial because it highlights why early intervention is life-saving. Interrupting this spiral can prevent irreversible cardiac failure and death. Let's focus now on how to recognize pulmonary embolism through its clinical presentation and physical findings. PE often presents abruptly, with sudden onset dyspnea being the most common symptom. Patients typically describe a sharp, pleuritic chest pain that worsens with inspiration. These symptoms reflect the sudden obstruction in the pulmonary vasculature and the resulting lung irritation. Vital signs frequently reveal tachycardia and tachypnea. Heart rates over 100 beats per minute and respiratory rates above 20 per minute are common. Hypoxia is also frequently present, with oxygen saturation often dropping below 95%, signaling impaired gas exchange. On physical exam, these findings are reinforced. You'll see rapid heart and respiratory rates, low oxygen levels, and in more severe cases, hypotension due to right ventricular strain. Elevated jugular venous pressure and a loud pulmonary component of the second heart sound, or loud P2, can indicate increased pulmonary artery pressures. Be alert for red flag symptoms. Syncope may signal a massive PE causing acute circulatory collapse. Hemoptysis suggests pulmonary infarction, and unilateral leg swelling raises suspicion for deep vein thrombosis, the usual source of emboli. Recognizing these signs early is critical to prompt diagnosis and management, which can be life-saving. Let's now focus on identifying patients who are at high risk for developing acute pulmonary embolism. Recognizing these risk factors early is crucial for both prevention and timely diagnosis. We start with the major risk factors which have a strong association with venous thromboembolism. Recent orthopedic surgery or significant trauma is a common trigger because it causes tissue injury and immobility, both contributing to clot formation. Active cancer, especially metastatic disease or patients undergoing chemotherapy, dramatically increases clotting risk due to tumor-related factors and treatment effects. Prolonged immobilization, such as being bedridden for more than 3 days, slows blood flow in the veins, promoting stasis. A history of prior venous thromboembolism, whether deep vein thrombosis or pulmonary embolism, is a red flag, as these patients have a predisposition to recurrent events. Pregnancy and the postpartum period are also high-risk times, owing to physiological hypercoagulability. Similarly, the use of oral contraceptives or hormone replacement therapy can tip the balance toward clot formation. Lastly, inherited thrombophilias, genetic conditions that increase clotting tendency, must always be considered. At the core of these risk factors lies Virchow's triad, which describes the 3 fundamental mechanisms that lead to thrombosis: stasis, endothelial injury, and hypercoagulability. Stasis refers to sluggish blood flow, endothelial injury is damage to the blood vessel lining, and hypercoagulability is an increased tendency of the blood to clot. Many of the risk factors we've mentioned influence one or more of these mechanisms. There are also moderate risk factors to keep in mind. Obesity, particularly a BMI over 30, contributes to venous stasis and inflammation. Heart failure and chronic lung disease cause circulatory compromise and hypoxia, which can promote clotting. Patients with stroke and paralysis have immobility and vascular changes that increase risk. Finally, central venous catheters can cause local endothelial injury and act as a nidus for clot formation. By integrating these risk factors with clinical judgment, you can better identify patients who need closer monitoring or prophylactic measures to prevent pulmonary embolism. Now, let's talk about the Wells score, a clinical tool we use to estimate the probability of pulmonary embolism in a patient. This score helps guide our diagnostic approach and management decisions. The Wells score is based on several key clinical factors, each assigned a specific point value reflecting its contribution to the likelihood of PE. For example, if the patient has signs or symptoms of deep vein thrombosis, such as leg swelling or tenderness, that adds 3 points. Similarly, if PE is considered more likely than any other diagnosis based on clinical judgment, that also scores 3 points. This subjective assessment is crucial and often reflects the clinician's overall impression. A heart rate above 100 beats per minute adds 1.5 points, as tachycardia is a common physiological response in PE. Immobilization or recent surgery within the past 4 weeks, previous history of DVT or PE, each contribute 1.5 points as well, reflecting known risk factors for thromboembolism. Hemoptysis adds 1 point, since coughing up blood can indicate pulmonary infarction or vessel injury. Lastly, active malignancy adds 1 point, due to the hypercoagulable state cancer induces. Once you sum these points, the interpretation can follow 2 approaches. The traditional method stratifies patients into low, moderate, or high probability categories, with scores below 2 indicating low probability, between 2 and 6 moderate, and above 6 high probability of PE. Alternatively, a simplified, modified approach groups patients into PE unlikely if the score is 4 or less, and PE likely if above 4. This dichotomous classification is often more practical in clinical settings. Using the Wells score effectively can help us decide when to order imaging like CT pulmonary angiography or when to consider D-dimer testing, ultimately improving patient care by targeting resources appropriately and avoiding unnecessary testing. Remember, while the Wells score is a valuable tool, it should always be integrated with clinical judgment and other findings to guide your management decisions. Now, let's discuss the PERC Rule, which stands for Pulmonary Embolism Rule-Out Criteria. This is a valuable clinical tool to help us decide when we can safely stop further testing for pulmonary embolism, especially in patients who have a low clinical suspicion and are not hospitalized. The PERC rule includes 8 criteria. If a patient meets all of these, their risk of PE is so low, less than 1%, that we can confidently exclude the diagnosis without additional testing. These criteria are age under 50 years, heart rate less than 100 beats per minute, oxygen saturation of 95% or higher, no hemoptysis, no current estrogen use, no history of prior deep vein thrombosis or pulmonary embolism, no unilateral leg swelling, and no recent surgery or trauma requiring hospitalization within the past 4 weeks. If even one of these criteria is not met, we cannot safely exclude PE and should proceed with further evaluation, typically starting with a D-dimer test. Using the PERC rule helps us avoid unnecessary imaging and invasive testing in low-risk patients, thereby reducing potential harm and healthcare costs. It's important to remember that this rule applies only to patients with a low pretest probability of PE, usually assessed by clinical judgment or validated scoring systems. Let's talk about the D-dimer test, often called the gatekeeper for evaluating suspected pulmonary embolism. Understanding this test is crucial because it helps us decide who needs further imaging and who doesn't. First, be very clear about the units reported by your lab. D-dimer results come in 2 main units: fibrinogen equivalent units, or FEU, and D-dimer units, DDU. The typical cutoff for FEU is around 500 nanograms per milliliter, while for DDU it's roughly half that, about 230 to 250 nanograms per milliliter. Confusing these can lead to misinterpretation, so always confirm your lab's reporting units. Now, on to the test characteristics. The D-dimer has very high sensitivity, over 95%, which means a negative result is quite reliable for ruling out PE, especially in patients with low to moderate pretest probability. However, its specificity is low, around 50%, so a positive D-dimer doesn't confirm PE. It simply tells us that further imaging is warranted. One important nuance is age adjustment. For patients over 50 years old, the traditional cutoff can yield many false positives. To improve specificity without losing sensitivity, we multiply the patient's age by 10 nanograms per milliliter when using FEU units. For example, a 70-year-old would have a cutoff of 700 nanograms per milliliter. This adjustment helps reduce unnecessary imaging in the elderly population. In summary, the D-dimer is a powerful tool to safely exclude PE when negative, but it's not diagnostic on its own. Always interpret it within the clinical context and remember the importance of units and age-adjusted thresholds. Now let's focus on CT pulmonary angiography, or CTPA, which is considered the gold standard for diagnosing acute pulmonary embolism. Its strength lies in its high sensitivity and specificity, meaning it's very accurate in confirming or ruling out PE. The test is also relatively quick to perform, which is crucial in emergency settings where time is of the essence. One of the major advantages of CTPA is that it not only detects emboli but can also reveal alternative diagnoses, such as pneumonia or aortic dissection, which can mimic PE symptoms. This comprehensive view can guide appropriate management beyond just confirming a clot. However, we must be mindful of its limitations. CTPA requires intravenous contrast, which carries a risk of nephropathy, especially in patients with pre-existing kidney dysfunction. There is also a risk of allergic reactions to the contrast dye. Additionally, the procedure exposes patients to ionizing radiation, a factor to consider particularly in young patients or those requiring multiple imaging studies. CTPA is excellent at detecting central and segmental emboli, but its sensitivity decreases for subsegmental PE, which can sometimes be missed. In cases where CTPA is contraindicated, such as severe contrast allergy or significant renal impairment, ventilation perfusion, or V/Q scanning, serves as a valuable alternative. The classic radiologic finding on CTPA is a filling defect within the pulmonary artery, representing the thrombus obstructing blood flow. When we see this filling defect, it confirms the diagnosis of PE. Conversely, if no filling defect is found, we can confidently exclude PE. In summary, CTPA remains the definitive diagnostic tool for pulmonary embolism, balancing rapid, accurate detection with some important considerations regarding patient safety and alternative testing options. Let's walk through the initial approach when you suspect a pulmonary embolism in a patient. The first step is to apply the PERC rule, the pulmonary embolism rule-out criteria, which consists of 8 clinical criteria designed to identify patients at very low risk of PE. If the patient meets all 8 criteria, and they are not hospitalized or otherwise high risk, you can effectively exclude PE without further testing. If the patient is hospitalized or doesn't meet all PERC criteria, the next step is to assess their pretest probability using a validated clinical prediction rule, like the Wells score or the modified Geneva score. This helps categorize patients into low, intermediate, or high probability for PE. For those with low probability, we proceed with D-dimer testing, ideally using an age-adjusted threshold if the patient is over 50. A negative D-dimer in this setting reliably excludes PE, reducing unnecessary imaging. If positive, or if the patient is intermediate or high probability, the next step is advanced imaging, typically a CT pulmonary angiogram or CTPA. In intermediate probability cases, be particularly cautious if the patient is toward the higher end of this category or has limited cardiopulmonary reserve. These factors may influence your management decisions. For high probability patients, it's generally appropriate to proceed directly to CTPA without D-dimer testing. In certain clinical scenarios, especially if imaging will be delayed, empiric anticoagulation may be considered. Once CTPA is performed, a positive result confirms PE, prompting risk stratification to guide treatment intensity and monitoring. A negative CTPA effectively excludes PE, and you should then evaluate for alternative diagnoses. If CTPA is contraindicated, for example due to contrast allergy or renal impairment, a ventilation perfusion scan is the alternative. A normal or very low probability V/Q scan excludes PE, while indeterminate results may require further testing or clinical judgment. This algorithmic approach balances safety and efficiency, minimizing unnecessary testing while ensuring timely diagnosis and treatment of PE. Let's talk about the electrocardiographic findings we often see in acute pulmonary embolism. ECG changes are quite common, occurring in about 70% of cases, but importantly, they tend to be nonspecific. The most frequent abnormality you'll encounter is sinus tachycardia, meaning the heart rate is elevated above 100 beats per minute. This makes sense physiologically, as the heart tries to compensate for impaired oxygenation and increased pulmonary vascular resistance. You might also notice nonspecific STT wave changes. These alterations don't point directly to PE, but rather reflect the strain on the right ventricle or generalized cardiac stress. Now, there are some ECG patterns more suggestive of right ventricular strain, although these are less common. The classic S1Q3T3 pattern, an S wave in lead I, Q wave in lead 3, and inverted T wave in lead 3, is well known but actually seen in fewer than 20% of patients. Another pattern to watch for is a new incomplete right bundle branch block, which indicates conduction delay in the right ventricle. Simultaneous T-wave inversions in the anteroseptal leads, V1 to V4, combined with inferior leads, 2, 3, AVF, also suggest significant right ventricular strain. Finally, bradycardia, although rare, is considered an ominous sign and may reflect severe hemodynamic compromise. A crucial clinical pearl here: a normal ECG does not exclude pulmonary embolism. While it's very useful to help rule out other diagnoses like myocardial infarction or pericarditis, you should never rely solely on the ECG to confirm or exclude PE. Always interpret it in the broader clinical context. Let's now discuss risk stratification in acute pulmonary embolism, which is crucial for tailoring the intensity of treatment to the patient's clinical status. Starting with high risk or massive PE, these patients present with sustained hypotension, meaning a systolic blood pressure below 90 millimeters of mercury, or may be in shock or even cardiac arrest. This group has a very high mortality risk, ranging from 15 to 50%. Because of this, prompt and aggressive intervention is essential. Activation of a pulmonary embolism response team, or PERT, helps coordinate care rapidly. Immediate reperfusion therapies like systemic thrombolysis, catheter-directed thrombolysis, or surgical embolectomy are typically indicated to restore pulmonary blood flow and prevent hemodynamic collapse. Next, we have intermediate risk, also referred to as submassive PE. These patients maintain stable blood pressure but show evidence of right ventricular dysfunction or elevated cardiac biomarkers like troponin, signaling myocardial strain. Within this category, we differentiate between intermediate high risk, where both RV dysfunction and biomarkers are positive, and intermediate low risk, where only one is positive. Treatment primarily involves therapeutic anticoagulation, but these patients require closer monitoring in an ICU or step-down unit to detect any clinical deterioration early. Finally, the low-risk group includes patients who are hemodynamically stable, have no signs of RV dysfunction, and normal cardiac biomarkers. Mortality in this group is very low, under 1 to 2%. Standard anticoagulation is sufficient here, and patients with a low simplified pulmonary embolism severity index, or SPACI score of 0, may even be suitable for outpatient management. Understanding these risk categories helps us balance the benefits and risks of treatment, ensuring that patients receive appropriate care without unnecessary interventions. Now, let's focus on the high-risk factors that predict a poor prognosis in acute pulmonary embolism. Recognizing these is crucial for risk stratification and guiding management. First, hemodynamic instability is a major red flag. Persistent hypotension or shock indicates that the embolism is severely compromising cardiac output. A heart rate over 120 beats per minute, especially if worsening blood pressure accompanies it, signals that the patient's cardiovascular system is struggling to compensate. Next, right ventricular dysfunction is a key indicator of severity. On echocardiography, we look for an enlarged right ventricle or an RV to LV ratio of 1 or greater, as well as septal bowing towards the left ventricle. On CT imaging, contrast reflux into the hepatic veins suggests elevated right heart pressures. Biomarkers like elevated troponin and BNP further support the presence of right ventricular strain or injury. Clinical factors also contribute to risk assessment. A simplified pulmonary embolism severity index, or SPACI score, of 1 or greater suggests increased risk. The presence of a proximal deep vein thrombosis raises the likelihood of ongoing embolic risk. Hypoxemia with oxygen saturation below 90%, visible clot in transit on imaging, advanced age over 65, and elevated lactate levels. All these point to more severe disease and worse outcomes. It's important to remember that no single factor alone, except for overt shock, should automatically prompt thrombolytic therapy. Instead, we must assess these variables collectively to make a balanced, informed decision about the aggressiveness of treatment. This comprehensive approach helps optimize patient outcomes while minimizing unnecessary risks. Let's now discuss the Simplified Pulmonary Embolism Severity Index, or SPACI, which is a practical tool to help us stratify risk in patients with acute pulmonary embolism and guide decisions about outpatient versus inpatient management. The SPACI assigns 1 point for each of 6 clinical criteria: age over 80, a history of cancer, chronic cardiopulmonary disease, heart rate of 110 beats per minute or higher, systolic blood pressure below 100 millimeters of mercury, and oxygen saturation under 90%. These factors reflect patient vulnerability and hemodynamic stress. If the patient scores 0, meaning none of these risk factors are present, they are considered low risk. In such cases, outpatient management can be safely considered, provided other conditions are met. However, a score of 1 or more indicates increased risk, and hospitalization is generally recommended. But low SPACI alone is not sufficient to send a patient home. We must also ensure there is no right ventricular dysfunction on imaging, normal troponin levels indicating no myocardial injury, adequate home support to ensure compliance and safety, and no significant bleeding risk that would contraindicate anticoagulation. By integrating SPACI with these additional criteria, we can confidently identify patients who may avoid hospital admission, improving resource utilization and patient comfort without compromising safety. Let's focus now on the role of cardiac biomarkers in assessing right ventricular strain in acute pulmonary embolism. 2 key biomarkers we routinely evaluate are troponins and natriuretic peptides, specifically BNP and NT-proBNP. Troponins, either I or T, are well-known markers of myocardial injury. In the context of PE, elevated troponin levels indicate that the right ventricle is under ischemic stress due to increased afterload. We see elevated troponins in about 30 to 50% of PE cases, and their presence correlates with a higher risk of mortality. Importantly, elevated troponin helps us identify patients in the intermediate risk category who may need closer monitoring or more aggressive management. Next, BNP and its inactive fragment NT-proBNP reflect ventricular wall stretch and dysfunction. When the right ventricle faces pressure overload from the embolism, it stretches, releasing these peptides. While elevated BNP suggests RV strain, a normal BNP or NT-proBNP has a high negative predictive value, meaning a normal result is reassuring and associated with a good prognosis. This makes natriuretic peptides especially useful for risk stratification. Clinically, we should measure both troponin and BNP or NT-proBNP in all patients with confirmed PE. If both biomarkers are elevated and imaging or echocardiography confirms RV dysfunction, this places the patient in the intermediate high-risk group, indicating a need for vigilant care. Conversely, if biomarkers are normal and there is no evidence of RV dysfunction, the patient is likely low risk and may be managed less intensively. In summary, combining biomarker assessment with imaging findings gives us a powerful approach to risk stratification in PE, helping tailor treatment decisions based on the severity of right ventricular strain. Let's focus now on echocardiographic findings that are crucial in assessing acute pulmonary embolism, particularly McConnell's sign and right ventricular strain. First, right ventricular dysfunction is a key indicator of significant PE. We look for dilation of the right ventricle, often measured as an RV to left ventricular ratio greater than 0.9. This suggests the right heart is under pressure and volume stress. Alongside dilation, hypokinesis or reduced movement of the RV free wall is important, as is septal flattening, which creates the classic D-sign appearance in the left ventricle on the parasternal short axis view. This indicates pressure overload shifting the septum. Additionally, tricuspid regurgitation with elevated right ventricular systolic pressure reflects increased RV afterload. McConnell's sign is a particularly interesting and somewhat specific finding in PE. It's characterized by akinesia or lack of movement of the mid-free wall of the right ventricle, with relative sparing of the apex, which continues to move normally. This pattern is thought to be due to regional differences in RV wall stress and ischemia. While not perfectly sensitive, it has approximately 60% specificity for pulmonary embolism, making it a valuable clue, especially in the right clinical context. Clinically, bedside echocardiography can be a rapid, non-invasive tool to identify these findings in unstable patients where immediate diagnosis is critical. Furthermore, identifying RV dysfunction and McConnell's sign helps us stratify risk. Patients with these findings are often considered intermediate risk and may require more aggressive monitoring and management. In summary, understanding and recognizing these echo patterns can greatly enhance our diagnostic accuracy and guide timely interventions in acute PE. Now let's focus on anticoagulation, which remains the cornerstone of treatment for acute pulmonary embolism. Direct oral anticoagulants, or DOACs, have become the first-line therapy for most patients. These include apixaban, rivaroxaban, edoxaban, and dabigatran. Their main advantages are that they are taken orally, don't require routine laboratory monitoring, and have a rapid onset of action. This makes them particularly convenient and effective for stable patients without contraindications. However, there are important exceptions. Unfractionated heparin is preferred in patients who are hemodynamically unstable, have significant renal impairment, or are at high risk of bleeding because it can be rapidly reversed and closely monitored. Low molecular weight heparin is often chosen for special populations, such as pregnant patients, those with active cancer, or patients with gastrointestinal malabsorption where oral agents may be less reliable. Fondaparinux is reserved primarily for patients with heparin-induced thrombocytopenia. A word of caution about warfarin. It should never be used alone as initial therapy because it takes several days to become therapeutic and can paradoxically increase clotting risk early on. Instead, warfarin must be started alongside heparin or a DOAC and only continued long-term once adequate anticoagulation is established. Finally, anticoagulation is contraindicated in patients with active bleeding, recent major surgery or trauma, recent intracranial hemorrhage, or severe thrombocytopenia. In these cases, the risks outweigh the benefits, and careful multidisciplinary evaluation is required. Understanding when and how to initiate anticoagulation is critical to effectively managing PE while minimizing complications. When managing suspected acute pulmonary embolism, the decision to start empiric anticoagulation before confirming the diagnosis is nuanced and must be individualized. The core principle here is to carefully balance the risks and benefits, considering the patient's clinical picture, hemodynamic status, and how long it might take to obtain definitive imaging. You should strongly consider empiric anticoagulation in patients with a high clinical probability of PE who are hemodynamically unstable, especially if there's expected delay in imaging beyond 4 to 6 hours, and if their bleeding risk is low. In these cases, the potential benefits of preventing clot progression and death often outweigh the bleeding risks. Conversely, avoid empiric anticoagulation when the clinical suspicion is low or intermediate and imaging can be obtained promptly. It's absolutely contraindicated in patients with active bleeding or those with conditions that significantly elevate bleeding risk, such as recent major surgery or trauma, recent hemorrhagic stroke, aortic dissection, central nervous system tumors, or severe thrombocytopenia below 50,000. Remember, starting empiric anticoagulation is not a reflexive step. It requires careful clinical judgment. Your decision must integrate the patient's stability, bleeding risk, and the practical realities of diagnostic timing to ensure the safest and most effective care.